Hello and welcome to today's webinar. My name is Ursel McElroy and I am the Director of the Ohio Department of Aging. Thank you for investing the next 90 minutes to gather information that will support your efforts to prepare a safe holiday season for your staff, residents, and their families. This time is dedicated to supporting you. We will spend the first half of our time together sharing pertinent information on updated regulations, guidance, and efforts relevant to COVID-19 in Ohio's long-term care facilities. The second half is dedicated to a live panel discussion with experts in pharmaceutical, post-acute, and long-term care. Although lines will be muted, I encourage you to engage by typing questions throughout, and we will make every effort to post a recording of this webinar along with helpful information, tools, and resources following today's event. Today I will be joined by our featured speakers, Rebecca Sandholt, Chief of the Bureau of Survey and Certification for the Ohio Department of Health, and Dr. John Wigan, Chief Medical Officer of the Regional Rapid Response Assistance Program, or what we refer to as RAP, Ohio's State Strike Force Team. I am also pleased to announce that Dr. Wigan now serves as the Chief Medical Director for the Ohio Department of Health and the Ohio Department of Aging. This is exciting news and a progressive step for Ohio to have such an accomplished and highly regarded long-term care expert in this newly created dual role. Please be assured that maintaining the integrity of RAP, along with his other duties, has been a central theme, and we look forward to his continued expertise in a variety of COVID-19 efforts as he transitions to his new position. I will also be joined by experts specializing in pharmaceutical care, post-acute care, and long-term care medicine. Dr. Jessica Coleman, Alan Fox, a registered pharmacist, Dr. Robin Jump, Dr. Thomas Lehner, and Dr. Todd Sobel. We will have an opportunity to engage with this live panel later within the hour to address some of the most pressing COVID-19 issues impacting the health and safety of the residents and staff of our long-term care facilities. The Centers for Medicare and Medicaid Services, or CMS, issued memoranda on November 12, 2021, QSO 2202 ALL and QSO 2039 NH. The first memorandum outlines changes to the COVID-19 state survey activities and emphasizes increased oversight in nursing homes. The second memorandum addresses nursing home visitation during the COVID-19 public health emergency. And while both specifically address nursing homes, the person-centered approach and adherence to the core principles of COVID-19 infection prevention can be applied in assisted living facilities, intermediate care facilities for individuals with intellectual disabilities, and other long-term care settings. I will take the next several minutes to address some of the high points. Since the beginning of the pandemic, CMS has provided guidance to nursing facilities on visitation. In March 2020, CMS issued a memorandum to facilities on restricting entry of all visitors and non-essential personnel, except for compassionate care situations such as end of life. In May 2020, CMS released nursing home reopening recommendations on visitation as states and local communities used a phased approach to reopening. Later in September 2020, CMS Memorandum QSO 2039 NH was released to provide additional guidance on visitation and communal activities. And last week, this memorandum was revised to reflect new guidance for visitation in nursing homes. In summary, the latest guidance makes clear that visitation is allowed for all residents at all times, and that facilities can no longer limit the frequency and length of visits for residents. the number of visitors, or require advanced scheduling. It also states that visitation can be conducted through different means based on a facility's structure and residents' needs. Some considerations include the location of a visit, such as in a resident's room, dedicated visitation space, indoor and outdoor. Yet, regardless of how visits are conducted, there are core principles and best practices that should be integrated in your operations to reduce the risk of COVID-19 transmission, while affording the resident and his or her family an adequate degree of privacy. Regardless of how visits are conducted, certain core principles and best practices reduce the risk of COVID-19 transmission. They include screening all who enter the facility, with an emphasis on visitors who have a positive viral test for COVID-19, symptoms of COVID-19, or currently meet the criteria for quarantine. These individuals should not enter the facility. We also emphasize practicing good hand hygiene, covering your mouth and nose with a face covering or mask, and physical distancing at least 6 feet, posting instructional signage throughout the building, cleaning and disinfecting high-touch surfaces, using appropriate personal protective equipment by staff, cohorting residents effectively, conducting resident and staff testing. The risk of transmission can be further reduced through the use of physical barriers such as plexiglass dividers and curtains. These core principles are consistent with the Centers for Disease Control and Prevention guidance and should be adhered to at all times. Visitors who are unable to adhere to these core principles should not be permitted to visit or should be asked to leave. By following a person-centered approach and adhering to these core principles, visitation can occur safely. So a bit about the facility's community level of transmission. If the nursing home's community level of transmission is substantial to high, all residents and visitors, regardless of vaccination status, should wear face coverings or masks and physically distance at all times. If the nursing home's community level of transmission is low to moderate, the safest practice is for residents and visitors to wear face coverings or masks and physically distance, particularly if either of them is at increased risk for severe disease or are unvaccinated. If the resident and all their visitors are fully vaccinated and the resident is not moderately or severely immunocompromised, they may choose not to wear face coverings or masks and to have physical contact. Visitors should wear face coverings or masks when around other residents or healthcare personnel, regardless of vaccination status. Residents who are on transmission-based precautions or quarantine can still receive visitors. In these cases, visits should occur in the resident's room, and the resident should wear a well-fitting mask. Visitors should also be made aware of the potential risks should they choose to visit. Finally, if a resident's roommate is unvaccinated or immunocompromised, regardless of vaccination status, these visits should not be conducted in the resident's room. At this moment, I'd like to turn the program over to Rebecca Sandholt, Chief of the Bureau of Survey and Certification with the Ohio Department of Health, to talk in more detail about the regulation. Rebecca?
Good afternoon. Thank you, Director McElroy and Dr. Wygant, for having me today. I would like to discuss the revised Quality and Safety Oversight Memo, QSO 2039NH, as well as the new QSO 22-02-all. Please note that these memos are only applicable to certified facilities. However, there is very good information in these memos that could be applicable to assisted living facilities as well. In summary, the QSO 2039NH memo now allows visitation for all residents at all times. CMS, in conjunction with CDC, is updating the visitation guidance while still emphasizing the importance of maintaining infection prevention practices. CMS and CDC note that staff vaccination rates remain significantly lower than resident vaccination rates. Therefore, they remain concerned about the transmission of the virus from unvaccinated staff to residents and are taking additional measures such as establishing staff vaccination requirement to mitigate the spread of COVID-19 and protect the residents. I'll talk more about the staff vaccination requirements in a little bit. In addition to the previous identified core principles of COVID-19 infection prevention, for example, hand hygiene, face coverings or masks, resident and staff testing, an additional one has been added to now address visitors. Visitors who have a positive viral test for COVID-19 are demonstrating symptoms of COVID-19 or meet the criteria for quarantine should not enter the facility. Facilities should still screen all who enter for these visitation exclusions. These core principles should be adhered to at all times. Some of the changes related to visitation, specifically to indoor visitation, include that a facility must allow indoor visitation at all times for all residents, as permitted under the regulations. Facilities can no longer limit the frequency, the length of visit for a resident, the number of visitors, or require advanced scheduling of visits. Although there is no limit on the number of visitors, visits should be conducted in a manner that adheres to the core principles of COVID-19 infection prevention, and it does not increase risk to other residents. For example, if a roommate's resident is unvaccinated or immunocompromised, regardless of the vaccination status, visits should not be conducted in the resident's room if possible. If the nursing home's county COVID-19 community level of transmission is substantial to high, all residents and visitors, regardless of vaccination status, should wear face coverings or masks and physically distance at all times. Next, let's talk about indoor visitation with an outbreak. When a new case of COVID-19 is identified among residents or staff, a facility should immediately begin outbreak testing in accordance with previously published QSO 2038NH revised, as well as CDC guidelines. While it's safer for visitors not to enter the facility during an outbreak investigation, visitors must still be allowed in the facility. Facilities should make visitors aware of the potential risks of visiting during an outbreak and continue to adhere to the core principles of infection prevention. If residents or their representatives would like to have a visit during an outbreak, they should wear face coverings or masks during visits, regardless of their vaccination status, and visits should ideally occur in the resident's room. Visitor testing and vaccination can help prevent the spread of COVID-19, and facilities may ask about a visitor's vaccination status. However, visitors are not required to be tested or vaccinated or show proof that they are vaccinated as a condition of visitation. If a visitor declines to disclose their vaccination status, the visitor should wear a face mask at all times. This would also apply to representatives of the Office of the State Long-Term Care Ombudsman, as well as protection and advocacy representatives. Facilities must permit residents to leave the facility as they choose. So with the holidays coming, you may have residents who want to go for Thanksgiving or celebrate Christmas with loved ones. And should a resident choose to leave, the facility should remind the resident and any individual accompanying the resident to follow all recommended infection prevention practices, including wearing a face covering or mask, physical distancing, and hand hygiene. It is also recommended that upon their return, that those residents are monitored for signs and symptoms of COVID-19. All healthcare workers must be permitted to come into the facility as long as they are not subject to a work exclusion or showing signs and symptoms of COVID-19. This healthcare workers includes home health, hospice, etc. In addition to healthcare workers, personnel educating and assisting in resident transitions to the community should be permitted entry consistent with this guidance. State survey agencies and CMS are ultimately responsible for ensuring surveyors are compliant with the applicable expectations. Therefore, long-term care facilities are not permitted to restrict access to surveyors based on vaccination status, nor ask a surveyor for proof of his or her vaccination status as a condition of entry. If facilities have questions about the process a state is using to ensure surveyors can enter a facility, those questions should be addressed to the state survey agency, or you can address those questions specifically to me. Additionally, as I mentioned at the very beginning, CMS issued a new Quality and Safety Oversight Memo, QSO 2202 All, to assist state survey agencies in addressing the backlog of complaints and recertification surveys. So these steps include revising the criteria for conducting COVID-19 focused infection control surveys, guidance for resuming recertification surveys, and temporary guidance and minor flexibilities related to complaint investigations. Additionally, CMS is increasing oversight in nursing homes to allow a more focused review of quality of life and quality of care concerns. So just to highlight some of the assistance that's being provided to the state survey agencies, we are no longer required to conduct focused infection control surveys within 3 to 5 days of an outbreak of COVID-19. Instead, states will conduct these surveys when concerns related to COVID or infection control arises. We will still be required to conduct focused infection control surveys in 20% of our nursing homes based upon the state's discretion versus CMS requiring certain facilities, as well as the time frame within 3 to 5 days has been removed. We will resume our normal survey schedule for recertifications moving forward. We do not need to conduct additional recertification surveys to make up for any surveys that we couldn't complete due to COVID. We are setting a new interval for each facility. CMS is also providing temporary guidance and minor flexibilities to help states work through the current backlog of complaints and recertification surveys. Ohio will continue to prioritize our recertification surveys based upon history of noncompliance. And CMS is allowing certain mandatory survey protocols tasks to be discretionary or triggered based upon concerns, i.e. resident council meetings, dining observation tasks, as well as medication storage. So those only need to be reviewed and looked at if they're triggered based upon a concern expressed during an interview with a resident. Complaints and self-reported incidences are still a priority, and the backlog of complaints and SRIs according to the level of triage. Ohio is current on our new 2 and 10-day complaints. However, we have a little over 1,200 backlog complaints for nursing homes and assisted living facilities. As you are all aware, the Biden-Harris administration issued an emergency regulation requiring COVID-19 vaccination for healthcare workers at healthcare facilities that participate in the Medicare and Medicaid programs. In addition to nursing homes, the staff vaccination requirement applies to other Medicare and Medicaid certified providers and supplier types. For example, ambulatory surgical centers, community mental health centers, end-stage renal disease facilities, home health agencies, hospice, hospitals, intermediate care facilities for individuals with intellectual disabilities, programs for all-inclusive care for the elderly organization, PACE, rural health clinics, federally qualified health centers, and so on. This vaccination requirement applies to eligible staff working at a facility that participates in the Medicare and Medicaid programs, regardless of clinical responsibility or patient contact. This requirement includes all current staff as well as any new staff who are providing any care, treatment, or other services for the facility and/or its patients. This includes facility employees, licensed practitioners, students, trainees, and volunteers. Additionally, this also includes individuals who provide care, treatment, or other services for the facility and/or its patients under contract or other arrangements. These requirements are not limited to those staff who perform their duties solely within a formal clinical setting. To ensure maximum patient protection, all staff who interact with other staff, patients, residents, clients, or PACE program participants in any location beyond the formal clinical setting, such as someone's home, a clinic, other sites of care, administrative offices, off-site meetings, etc., must be vaccinated. Additionally, a physician admitting or treating patients in person within a facility is subject to the CMS health and safety regulations, and they are included as part of this requirement. They must be vaccinated so that the facility is compliant. Facilities covered by this regulation must establish a policy ensuring that all eligible staff have received the first dose of a 2-dose COVID-19 vaccine, either the Moderna or the Pfizer, or a 1-dose COVID-19 vaccine, Johnson & Johnson, prior to providing any care, treatment, or other services by December 5th, 2021. All eligible staff must have received the necessary shots to be fully vaccinated, either the 2nd dose of the Pfizer or Moderna or the 1 dose of the Johnson & Johnson by January 4th, 2022. This regulation does not establish any new data reporting requirements. However, hospitals and long-term care facilities, our nursing homes, are expected to continue to comply with their facility-specific data reporting requirements that have been set forth in the emergency regulations that were issued previously by CMS. Facilities have flexibility to establish their own processes that permit staff to request a medical exemption from the COVID-19 vaccination requirements. Facilities must ensure that all documentation confirming recognized clinical contraindications to the COVID-19 vaccinations for staff seeking a medical exemption are signed and dated by a licensed practitioner who is not the individual requesting the exemption and is acting within their respective scope of practice based on the applicable state and local laws. This documentation must contain all the information specifying which of the authorized COVID-19 vaccines are clinically contraindicated for the staff member to receive, as well as the recognized clinical reasons for the contraindication. Additionally, a statement by the authenticating practitioner recommending that the staff member be exempted from the facility's COVID-19 vaccination requirements is also expected within that policy and the documentation. For any staff member who meets the requirements for an exemption, the regulation requires that facilities develop a process for implementing additional precautions for any staff who are not vaccinated in order to mitigate the transmission and spread of COVID-19. As a reminder, under federal law, including the ADA and Title VII of the Civil Rights Act of 1964, individuals who cannot be vaccinated because of medical conditions or seriously held religious beliefs, practice, or observance may be entitled to an accommodation. Now let's talk about survey and enforcement of this new regulation. CMS expects state survey agencies to conduct on-site compliance reviews of these requirements in two ways. State survey agencies would assess all facilities for these requirements during the standard recertification survey. And state survey agencies would assess vaccination status of staff on all complaint surveys. While on site, the surveyor will review the facility's COVID-19 vaccination policies and procedures, the number of residents and staff COVID-19 cases in the building over the last 4 weeks, and a list of all staff and their vaccination status. This information, in addition to interviews and observations, will be used to determine the compliance of the provider or supplier with these requirements. I would also state that anyone with a medical exemption, that supporting documentation should be available for review upon request. Medicare and Medicaid certified facilities are expected to comply with all regulatory requirements, and CMS has a variety of established enforcement remedies. For nursing homes, home health, and hospice, beginning in 2022, these enforcement actions can include civil money penalties, denial of payment, and even termination from the Medicare and Medicaid program as a final measure. I would state that state survey agencies have not received an updated survey process to work through, so we are still waiting additional guidance from CMS. Any additional guidance will come out through QSO memos to us. Additionally, I know there have been questions around surveyor vaccination, and we are waiting for guidance from CMS on that process as well. So I'd like to thank all of you for the opportunity to speak with you today, and I look forward to any questions that you may have. Thank you.
Thank you, Rebecca. Now we will talk about vaccination. Since the release of QSO Memorandum 2039-NH, COVID-19 vaccines have received full approval and emergency use authorization from the Food and Drug Administration. Vaccinations have since been administered to nursing home residents and staff, and these vaccines have been shown to help prevent symptomatic SARS-CoV-2 infection, or COVID-19. CMS requires nursing homes to educate residents and staff on the risks and benefits of the vaccines, to offer to administer the vaccine, and report resident and staff vaccination data to CDC's National Healthcare Safety Network. CMS now posts this information on the CMS COVID-19 Nursing Home Data website, along with other COVID-19 data, such as the weekly number of COVID-19 cases and deaths. Within Ohio, the state-supported COVID-19 vaccine maintenance program is the framework we are using to administer primary series COVID-19 vaccine and booster shots. While participation in the state-supported program is optional, it is expected that every facility will establish a process for routinely vaccinating new residents, new staff, and those choosing to be vaccinated. This includes booster shots. Originally launched in February 2021, the program builds upon existing relationships between the facilities and their long-term care pharmacies that already provide essential prescription medications medication therapy management, and other consultative services. As of today, of the 1,751 active facilities in Ohio, 1,499 have opted into the state-supported vaccine maintenance program. The remaining 252 facilities have shared their plans to use other partners, such as local health departments, local hospital systems, and retail pharmacies. We also have 38 long-term care pharmacies participating in the maintenance program. These pharmacies, alongside the long-term care facilities, have hosted 2,133 booster clinics, with an existing 96 clinics still scheduled through November 30th. To date, 40,375 booster doses have been reported. It's important to note that this data is quite fluid, as facilities and pharmacies add clinics and report vaccination numbers daily. Staff vaccinations, however, remain significantly lower than resident vaccination rates. For example, 743 assisted living facilities and 678 nursing homes have greater than 75% vaccination rates for their residents. Yet 294 assisted living facilities and 94 nursing homes have greater than 75% vaccination rates for staff. We highly encourage you to continue to educate and to encourage your staff to become vaccinated. We also encourage you to utilize the vaccine maintenance program for support. At this time, each facility should have received their vaccine portal guidance and credentials, had the opportunity to connect with an enrolled pharmacy to schedule vaccine and booster clinics. And by now, each facility should have hosted at a minimum one booster shot clinic. And now I'll take a moment to discuss testing. While we are fortunate to have ample supply of vaccine, we don't want to lose sight of the importance of layers of protection. The core principles of infection prevention include testing of residents and staff. The state-supported testing program remains available to long-term care facilities at no cost and with multiple options. Utilizing the self-service care center portal that most of you should be familiar with, you can still order alternating PCR and rapid antigen tests only, or PCR tests only. Should you have any testing needs or any questions around supply or delivery, as always, please reach out to the state-supported testing team. And now we'll move into our Regional Rapid Response Assistance Program, or what we refer to as RAP, Ohio's State Strike Force Team. I'd like to turn the program over to Dr. John Wigan, Chief Medical Officer of RAP. Dr. Wigan?
Thank you, Director. It's great to be here again and provide some information to the facilities that are listening today. We will first start with kind of a summary of our outreach through the RAP program. Every week we make outreach calls based on the number of facilities that have been identified as being in outbreak. And so we'll discuss this over a 2-month period. You know, I like music and I have a somewhat wide variety of musical genres that I like. And one of my favorite is a gentleman named Robert Johnson, who sings Delta Blues. And so I have to say that I kind of feel like I've been singing the Delta Blues along with all of you over the last 3 or 4 months. And so if we look at this first graph, which is facility outbreaks. And this is from the beginning of September through the beginning of November. You can see that we have consistently been around 40, at least 40 until recently, peaking around the end of September at about 77 facilities. But I don't think that that really tells the story of the extent of the Delta surge. This second graph is the number of resident and staff cases throughout Ohio. And you can see the red being staff cases and blue being resident cases really peaked in late September, early October with over 800 cases in staff members and almost 700 in residents. And those have gone down, but certainly not to the degree that the number of facilities have gone down. So what that tells me is fewer facilities continue to have significant outbreaks. So instead of 1 or 2 or 5 cases, we're having facilities now that have really large outbreaks. And so we want to try to help in any way that we can through the WRAP program to be able to help avoid these outbreaks, or if they occur, what we can do to try to help. So a couple takeaways from this 2-month snapshot is really in July and August, the Delta variant really came through unvaccinated staff. But by September, it was really all comers. It was vaccinated residents. And, we know that at least, if not greater than 90% of the residents in the facilities that have had outbreaks oftentimes are vaccinated. And even the staff, will vary between 25 and 65% vaccinated status. And they were continuing to increase 30% each week through September and the beginning of October. And of course, some of these are breakthrough cases, fully vaccinated residents and staff. And what that suggests to us is a waning immunity from the COVID vaccines that were given very early in 2021. And that really demonstrated evidence for the need of boosters. And so highly recommend boosters for individuals who are eligible for those based on the criteria of at least 6 months, and the boosters are beneficial. The number of severe cases of COVID-19 among the vaccinated residents has really remained in that 10 to 15% range, which was consistent with what the original estimates of protection were provided by the vaccine. And it's just that we've had so many more cases that we've had, significant cases of severe COVID and even death among our residents. And so the strategies remain very consistent to what we've said in the past. It's the core principles of infection prevention. And although that sounds like a broken record, when we've been able to go in and help facilities identify how COVID came in, oftentimes it was a staff member or a visitor who did not perform those core principles of hand washing or hand sanitization or wearing mask or PPE or doing the things that we know prevent the spread of this virus. And then a thoughtful assessment through contact tracing really can help shed light on how it might have come in so that can be prevented in the future. And then recently we've seen, and in some of the more recent recommendations, which we'll talk about in the panel, is the idea of voluntary testing of visitors. And we've seen some facilities that we've reached out to who have started doing this and effectively identifying people before they come in. as being asymptomatic carriers of COVID. And so really the last point that we found over the course of the last several months is the success that we've seen in the use of monoclonal antibody treatments. And so I'm going to spend a little bit of time going over that. And this is really one of the central focuses of the WRAP program. We have helped try to facilitate the supply of monoclonal antibody treatments to congregate care pharmacy partners. So when you reach out to your pharmacies, they have it. We've encouraged the use of antibodies in the facility, and we have a newly created playbook, which is at your disposal. And what we've seen is that it's safe and very effective. It has avoided the transfer of residents to the hospital, which the hospitals are undergoing, continue to undergo significant problems with unavailability of beds. They're basically many, really throughout Ohio, continuing to have people being held in the emergency room because they don't have beds. And so we want to try to prevent transfers to the hospital. And then, more recently, we've had facilities ask for whether or not COVID positive staff could be given monoclonal antibody treatment. And one of the things that the Department of Aging and in conjunction with the Department of Health have gone through that. And we are setting up methods through which the pharmacy can provide that for your staff if the facility is willing to give that. And I'll use one example of a facility that we've talked to within the last several weeks that have lost, I think it was somewhere between 600 and 700 employee days during the Delta COVID surge. That is an immense burden on facilities. And so the use of monoclonal antibody can decrease the length of time a staff member feels ill. Granted, there's a 10-day isolation period, but many times our staff members are out for 14 or 20 or 25 days. And if we can make those infections negligible or barely symptomatic, people can return at 10 days and it takes the burden off of coworkers. And so the WRAP program has provided education to facility staff and medical directors or other providers in facilities through the playbook. We've had medical directors from WRAP give in-services to staff and medical directors, physicians, and the like, and we're happy to do that. And we have this free consultation with the infection control prevention specialists at Leaderstat through the WRAP program. And so we strongly encourage you to use those. So briefly, for those of you who don't know what monoclonal antibodies treatments are, Regencove is the current preferred agent. It actually has a combination of 2 active agents, and it's given either through an IV infusion over half an hour to an hour, or a subcutaneous injection, actually 4 injections. And before you think that 4 injections sound terrible, they're actually very small gauge needles, and I call it the Macarena shot. It's given in a shoulder, a hip, and it is especially effective in residents who have cognitive impairment who aren't going to tolerate an IV over an extended period of time. Although this is a agent that has received emergency use authorization, we have used hundreds and probably thousands of doses of this, and it is safe and well received in the congregate care setting. It should be used in mild to moderate symptoms if somebody is COVID positive, and the sooner the better. It does require observation for an hour following treatment because of the emergency use authorization. But it's worth thinking about, and it's preparing for it, because I think of it as a fire drill philosophy. You don't want to try to figure out where the fire extinguisher is when you're in the midst of a blaze. Um, Planning is so important. Contacting the pharmacy to make sure that they have it in advance before you even need it, because invariably what we've seen is the outbreaks when you want to use it occur on Friday afternoon around 3 o'clock. It's crazy. It seems like it's always on Friday. So the common indications for the use of monoclonal antibody are any of these. So think about the residents that we care for and how they almost all will have at least one of these. An age older than 65 years of age, obesity or being overweight greater than a BMI of 25. So I qualify based on that one. Pregnancy isn't one that we certainly see, but in staff members, actually, the use of monoclonal antibody in pregnancy is really recommended because, COVID can really be severe in pregnancy. And so monoclonal antibodies are recommended in those situations. Diabetes, chronic kidney disease, cardiovascular disease or hypertension, chronic lung disease, or any immunosuppressive treatment like steroids, oral steroids, or diseases like cancer or rheumatologic conditions all qualify somebody for the use of monoclonal antibody if they become COVID positive. So I'm going to pause there because really I want to leave enough time for the panel, which is usually where we get the most positive responses from our webinars. There are so many things that are going on right now with visitation, with the antibody, monoclonal antibodies, like I mentioned, with vaccinations and boosters, that I want to leave enough time for questions. But before I do that, I do want to pause at this time of Thanksgiving to express not only my gratitude, but the entire RAP team's gratitude for what you do every day in our facilities, taking care of the residents and taking care of one another in congregate settings. We could not do this without you, and your care and compassion. There aren't words for us to express what that means to not only us, but all of Ohio. Thank you.
So I think now I'd like our panelists to join me, and we will start the question and answer period of the broadcast. So some of these individuals will be familiar faces, and I know we had talked about Dr. Jump being on. She may join us before the end of the broadcast. But I'd like to go ahead, and I'm not going to have you introduce yourselves. If people don't know who you are, then they can try to find out, but or if you want to give a little bit of an introduction, you can do so. We know who you are, Director. But let's go ahead and start with, I'll just pose a couple questions here, and certainly the panel can chime in if there are additional comments that you'd like to make. And so Dr. Lehner, do you mind if we start with you? Can you, and I know that you go into facilities as medical director and as a physician. can you kind of speak to the importance of the screening process for visitors? I think sometimes I've heard facilities say that, they aren't identifying people who are, have symptoms or anything. So they feel like it's just an unnecessary step that is standing in the way between the visitor and their loved one. Can you speak to that a little bit?
Sure, Dr. Wagon, thanks. And I apologize for the sun on the side. I know it's always a sunny day when you don't want it to be one. But as far as visitation, I do go into buildings, and it is brought up. They think it's a useless exercise to do the screening and ask the questions and check the temperature. But we know that if we ask the questions, some people don't take some of these symptoms seriously or may not recognize the symptoms they have. And so being posed with those questions oftentimes identifies people that may be minimally symptomatic or have had other situations that may cause them to be exposed to the virus and pose a threat to staff and family members that they're coming to visit. So, visitation should be allowed, as we've talked about for the last hour or so. But also the screening process should be continued and extremely important. And if a visitor has a positive test or they exhibit symptoms that might be suggestive of COVID, or they have quarantine conditions that would be eligible for them, they should not be allowed to enter the facility.
Great. Any other comments from Rebecca or anybody else? I know that that's a challenge that we've seen, but I think it is important to maintain. Once again, it's a core principle to avoid this. So Dr. Coleman, I'll just move across my screen here. You're next up. How should facilities handle requests for large parties of visitors? I think we've, and maybe we can go into, residents leaving, but like in the holidays, if there are families that are now going to be coming in, or if somebody has a birthday, how would you recommend facilities kind of deal with that extra burden?
I think this is a great question, and if it hasn't come up at your facility, I'm sure it's going to very soon. I think the key word in this question is creativity, and the next word is infection control. It's going to be really important to think about things like your physical plant. Is there a space in your facility where you can do this safely and away from other residents? Can you provide social distancing? Can you provide encouragement and education for hand hygiene and appropriate mask wearing? But what I would hate to see is facilities automatically saying, no, we're not going to do it. I think what the response needs to be is, okay, this is really important to you as our resident. Let's talk about what are we celebrating and how's a creative way that we can do it safely. Not to say that, you want to become a party center and start catering weddings of 300, but I think it's important to keep it within the scope of doing what's best for that resident and for their family in a way that fits in your building, fits within that culture, and fits the infection control practices.
Great. Unless the wedding is among two of the residents, which I've seen that happen in some of my facilities. So let's actually stick on this kind of this topic of how you go about managing. So let's say, and this is going to happen next week. I mean, let's be honest, it's Thanksgiving. There are going to be residents who want to go out to their family and enjoy Thanksgiving dinner and stay overnight, perhaps. How should we go about managing the residents as they come back to the facility? What advice can you, and we'll start with you, Dr. Coleman, and then let's open it up to the rest of the panel of any additional consideration that we need to think about.
Well, I think it starts this week with education, educating your staff and your residents about staying safe during the holidays, wearing your mask, using hand sanitizer, disinfecting commonly touched surfaces, social distancing as much as able, and educating folks on that before they go out and have that big turkey dinner. And then when they come back, asking those questions about, really the basic screening questions that we're asking our staff and visitors every day. And then from that point, determining based on risk, whether or not they maybe need to be tested or if they need to be quarantined, and really taking into account, one, what was the risk, and two, what's their vaccination status. But again, it's taking that resident-based approach of, yeah, I was there and then I got a call. Turns out my nephew was COVID positive. Okay, well, are you vaccinated? Great. Let's test you based on your exposure. Or you're not vaccinated. You were eating your turkey leg right next to cousin Joe, who's now COVID positive. Then maybe we need to quarantine you.
Other thoughts from other individuals? What happens if that? Oh, go ahead. Yeah.
I was just going to say, the only other thought I would have is you should make sure you talk to the residents about what you expect and what they can expect before they leave. Because when they come back in, you'd hate to barrage them with these, testing and other questions, and and then possibly quarantining. In the event that they're prepared for that, you're going to have a fight on your hands. And the other thing is, if they know they may have to undergo some of these things, they may be more cautious when they go out. They may be cautious about not sitting next to the cousin with the turkey leg and who's maybe get sniffles and a cough and a fever. They may not want to go near that person because they know when they come back, they're going to have to be quarantined for a period of time. So I think preparation is important.
And I would also add, continue to follow your infection protocols, your infection control protocols that you've been working throughout the pandemic. Because I think, although we've undergone some changes here, those infection protocols have been effective, and we do want to make sure that we comply with those.
So if the resident, let's say 2 days later, develops sniffles or something like that, how should we proceed in that case? What should the facility do? Open question.
In those cases, just like any other resident who develops COVID concerning symptoms, you would go ahead and test them.
And then I guess it would be important to continue transmission-based protocol in that situation. Okay. All right, Dr. Sobel, you first of all, I want to thank you. So when you read the playbook, that you'll read, there's a introductory letter by Dr. Sobel. So now you know who wrote it, and he was instrumental in advocating for monoclonal antibodies. So I'm going to lean on you a little bit. Let's talk a little bit about that. So. What's your experience, I guess? Probably of all the panelists, you have used the monoclonal antibody treatments more than all of us combined. What guidance can you give us about that?
Monoclonal antibody treatments have truly been life-saving, particularly for those frail patients who are at highest risk. In fact, some of the studies have shown a 70% decline in the need for patients to be hospitalized or all-cause mortality. The monoclonal antibodies impact a patient's COVID illness by basically decreasing the viral load, the amount of virus that a patient has. So think about approaching the front door of your house with a key. The monoclonal antibody changes the shape of that key so that it will no longer fit into the lock. And this prevents entry of the virus into the host. A patient who does not produce as much virus will not get as ill. And less virus production in the COVID positive patient benefits both the staff as well as all those living in the facility. Less virus is available to spread within the facility, and this is going to decrease the number of cases and the amount of the outbreak. And patients who do not develop as severe of an illness and fewer patients who contract the illness means less staff workload. So it has had a tremendously positive impact.
Terrific. Is Alan Fox on? Let's see.
Sorry, John. Can
Oh,
you hear
so
me?
Yeah, I can hear you just fine. Let me go ahead and ask you. Well, you're the man behind the screen apparently. So let's talk a little bit, since monoclonal antibody, we've talked about that. I know there's a lot of information now about these oral antivirals, and I was wondering if you could speak a little bit about that.
Sure, be happy to. What we know is that there's two oral products that will be reviewed on the 30th of this month by the FDA and their partners. We've gotten this all by press release. And so a little bit suspect, the scientific articles haven't come out yet, but they will. And the one by Merck is proven to decrease hospitalization or death by 50%. And the one by Pfizer that we talked about yesterday needs to be taken in combination with ritonavir, and they reduced hospitalization by 89%. But I'm a little bit weary of getting the cart before the horse. Again, these products haven't been approved yet, or even for emergency use. When they do, we're also not exactly sure how the distribution is going to be. We expect that our team will do our best to make it available, but there's going to be some limitations because they're not made up to the, they don't have enough doses to cover everybody at this time. The good news, again, is that they'll be oral, and it's a 5-day treatment BID. So we'll have to wait and see with everybody else what the emergency use authorization may look like when they come. But we're on the verge of really great things right now.
Any other experience from any of the other panelists in regard to that? I know that you're all waiting for that technology to become available. Okay. Well, you know, Director, you're just sitting over in the corner there. I don't want to catch you off guard here, but you know, the bottom line is certainly in our outreach calls, staffing continues to be probably the biggest single problem that our facilities are experiencing. And so can you kind of speak to kind of where we are with staffing from a state response standpoint?
So thank you, Dr. Wyden, for giving me one of the harder questions. No, seriously, I think what has happened during the pandemic is that there is appreciation, or I think more emphasis on the value of this critical workforce. I think many of us who've been in long-term care have known this for a while, but I think now others are seeing and understanding. I think this is really a two-part issue. There's going to be a need for short-term responses, but also a more long-term thoughtful response, a more long-term response that contemplates the pipeline and how we will get people into this field, what will attract them, what will retain them. I will say that more short-term, however, there have been dollars that have flowed into the state from the federal government that have allowed us in different instances to provide some sort of relief, but we understand that's only been temporary. As it stands right now, we know that many of the facilities are in desperate need of having staff who are qualified, who are paid well, and we have been, as a part of RAP, working to find solutions through maybe staffing agencies to see where we can be perhaps even more supportive than just picking up some of the administrative costs. I know we're examining that right now. We are also looking at some of the federal dollars that are coming in to see if those too could help support some of these more short-term or urgent needs. So there is a very, I would say, continuous and robust review of what exists, appreciation for the need. And then finally, we do still have access to, in those emergency situations, the Ohio National Guard. There has been extension on their time. And so if we have a facility that has a pretty urgent need,
certainly we would again ask for you to reach out to RAP, and we will see what we can do to be supportive to help you in these very desperate times.
Thank you. Dr. Coleman, so I know we've certainly been thinking about vaccination mandates and the like. What increased protocols would you suggest that we recommend being put in place for staff members who have those religious or medical exemptions and therefore remain unvaccinated?
I think this one will be a tough one. And the main idea, the overarching principle, is that we want to protect those who are at highest risk. Who's at highest risk? Those are our residents. The other highest risk population we need to think about are these unvaccinated staff members. So it's about protecting our residents, and it's about protecting our staff. Clearly it goes without saying that we're an understaffed industry. So those who cannot get vaccinated for either reason, we need to make sure we're protecting them. So that may look like increased testing. That may look like increased PPE use. And we have to think about exceptions, meaning workplace exceptions, such as if you are unable to be vaccinated, then maybe that's not somebody you put in a situation like a COVID unit, or to work with people who are on transmission-based precautions because you're concerned they may have COVID. Now, the QSO itself, the federal mandate itself does not explicitly say what those increased precautions should be, but it's very clear that the idea is to have a clearly written and defined process and a clearly written and defined way that you're going to protect your residents. So this is something that will need to be facility-based, but I would sit down with your leadership team and talk about what is this going to look like in our facility. And it may vary. It may be based on what is the community spread at that time. You may de-escalate based on community transmission for those who are vaccinated, but that de-escalation may not happen for those who are unvaccinated in terms of PPE use and testing cadence.
Okay, thank you. Dr. Sobel, let's just go back. I think one of the things that we found through the RAP program has been that sometimes physicians who would be ordering that have been resistant to doing it. They're afraid of it. They think it's a higher risk procedure. Can you speak to that?
So really, after giving several hundred of these infusions across the state, we've seen very minimal side effects, mainly skin irritation associated with the injection site. It really has been proven to be very, very well tolerated. We take appropriate precautions. The pharmacists will send over medications to prevent respiratory illness or any kind of an allergic reaction, and we're very well prepared should these events occur, but we just absolutely have not seen very many, and the studies actually initially said there would be less than 1%, and I think that's kind of where we are with these side effects. It's very easy to administer. The medication takes anywhere from 20 minutes to an hour. And so the time is well worth it to get it infused.
So, Dr. Wigan, I would like to, for a moment, I do want to, we have several comments or questions coming in, so I do want to at least make sure that I share some of those with some of the panelists. And there are many comments about the staffing and the high prices that are being charged by some of the staffing agencies, and there are questions about what will happen and what we will do. What I would like to offer to people is that we are acutely aware of this, and we know that those concerns have been brought forward, and we do believe that we are having the right discussions to see how we can move forward with this, what we understand is certainly a big concern in the industry. So I don't want anyone who's put those comments in to think that that has been lost. So I did want to point that out. There were also comments around the hours of RAP and availability for staffing and other services that could be needed. Again, I do think it's worth mentioning that we have also heard those concerns, and we are working on a process to make individuals more available both in the evenings and weekends. And so once we have solidified that, we will certainly share that. But that is something that we are actively working on now because we have heard those concerns raised with the response team. There are some questions here related to, there was a bit about quarantine. I want to make sure I ask the question exactly as it is asked. Just a moment here. Had to do with, just a second here. Yeah, a lot of them just sort of came all the way in, so I kind of pushed that one down. So just give me just a minute. So I'll ask this one before I go to that one. This is around the surveyors, Rebecca, and it's a comment and then it's wrapped into a question. And ultimately, the comment is around state surveyors not being mandated to be vaccinated, but they're exposed to more residents and staff by going to different buildings. And so I guess the question is, this leader is saying, how can he or she explain that to their staff members, and anything you can share about how your surveyors are working to keep both themselves and others in the building safe?
Yes, thank you. So I would say a couple of things. One, CMS has indicated that there will be some additional guidance coming out around surveyors and vaccine. What that looks like, I am not sure. We are, like everyone else, awaiting that guidance. What I'll tell you is that my surveyors who are unvaccinated, they are continue to be tested weekly. They also are required to go through your screening process at your facility. If they are experiencing signs and symptoms, they have those sniffles, they will notify our manager, notify our HR department. We work with our Bureau of Infectious Diseases at the health department to determine what that employee needs to do. If they need to, isolate or quarantine, we limit their work so they're not in a facility. We provide them other work that they can do from home until we receive their test results back. The other thing I will say is the surveyors are equipped with appropriate and sufficient amount of PPE. They are fit tested. They have surgical masks, face shields, gowns to use in the COVID areas of the building, also when they're interacting and talking with staff or residents. So we are taking every precaution that we can, just like all of you are taking with your staff.
Thank you, Rebecca. Thank you. There's a question about where people, when can they get the monoclonal antibody playbook? I do understand, Dr. Wyden, that is pretty much ready to go, so it just needs to be popped online. Is that correct? And
yeah, I have reviewed the final draft of that, and I think the printing presses are rolling.
Okay.
It actually is an electronic version, so we can just send it to you.
Okay. All right. All right. And I want to let you go ahead with yours. I want to make sure I'm not missing anything. There were a couple of questions though about with the oral treatments or what's out there now. Is that going to make the monoclonal antibodies obsolete? That's come up a couple times in these questions.
Yeah, go ahead, Alan.
I think that we need to continue to treat the Regencove as the hallmark of our treatment until there's some proof and availability that shows differently. So although I think in the future there may be some changes, right now we have monoclonal antibodies. We have the pharmacies teed up and the training out on monoclonal antibodies, and that has to be our hallmark of treatment today. What can happen tomorrow, we're not sure. These medications don't even have emergency use authorization yet.
Thank you.
If I could make a comment about the monoclonal antibody. It's a little bit disappointing that nationally the use of the monoclonal antibody has been very low, and there's plenty of product available. And so we encourage the medical directors and the facilities to treat their patients that meet the criteria for the use of the monoclonal antibody. It's not been widely used, probably because it's not been widely marketed. But in Ohio and with the RAP program, they've done a fabulous job of making it available, and strongly encourage you to use it on your residents that qualify.
So,
There are some questions about the testing resource. I do want to answer this. I'm seeing a few of those come in. At this time, we are still able to and intend to continue to provide the tests. Should anything change, we certainly would notify you, but we have no intention of that. I can tell you that we have extended contracts to keep the testing going because we understand how important a resource it is. So should anything change, we would certainly provide ample notice, but at this time, we intend to continue providing that resource.
So I'm going to throw one up to the panel really quickly because Director mentioned quarantine. So this will be kind of, I'll give the name, I'll say the word, and you let us know when you think it's most applicable to residents either going out or coming in. How's that?
We're about down to 2. So you all have to answer pretty quickly. You've got about 2-3 minutes on this one.
So what's the appropriate use of quarantine for residents? Let's say they are vaccinated. Is there an appropriate use of quarantine? I'm not going to call on anybody, so just speak up.
If they're symptomatic, yes.
Okay. So obviously symptomatic and doing the testing, and then, yeah, okay. And so it's probably easier in an unvaccinated individual. So if they've gone out to outside of the community, the facility, and they come back, is that at what point does quarantine seem to be the appropriate? If they've been identified as being exposed to somebody outside?
Yeah, if they're unvaccinated and they've had an exposure.
Or you're not certain of their exposure, if there's any question about their exposure.
And Director, I want to end with you, if you don't mind, because I know that we have talked about the RAP program being completed at the end of this year. Do you see a further role for the RAP program extending into the new year?
Absolutely. I want to be certain that we still have the infrastructure to provide the needed support to long-term care facilities, whether that be through testing, vaccine, outreach assistance during an outbreak, PPE, whatever those needs are, monoclonal antibodies. So we are certainly planning to continue to move forward. In fact, we are very excited about a potential opportunity for funding from the CDC for state strike force teams. And so we feel really good. We feel like we're positioned well, and we look forward to continuing to work with everyone. Unless you have any other questions for us, Dr. Wigan, I do want to take time to thank everyone. And again, we appreciate you hanging in there with us. Looks like technology was not our best friend today. We even had a few funny moments. So that being said, sometimes you need a little levity in these very, I would say, hot and important and heavy topics. So thank you for being here today. And again, if you need anything from us, we're here.
Happy Thanksgiving.
Absolutely.